Okay, good morning everyone. Today we will have a look at the second last topic, which is also the second topic under learning approach. So we're gonna look at the study by Saavedra and Silverman, which was done in 2002, which was a case study. So if you never had a case study before, now if you remember, a case study is basically when we only study one participant in details. Okay, so here we're gonna look at this boy who has a specific phobia of buttons. Okay, so the sight of buttons, he is disgusted by it. Okay, now, so we'll start with talking about what is phobia. So, phobia is a type of anxiety disorder defined by a persistent and excessive fear of an object or situation. The phobia typically results in a rapid onset of fear, so the sight of it makes you scared, trembling, okay, and is present for more than 6 months. Now, there are different types of phobias. There's acrophobia, which is fear of height. There's claustrophobia, which is a fear of small spaces. There's arachnophobia, which is a fear of spiders. Now, if you watch Harry Potter, Ron Weasley has this arachnophobia. Okay. There's aerophobia, which is a fear of flying. Now, I would say that I'm scared of flying, but I wouldn't say I have a phobia of it. Okay? For someone with aerophobia is that even going to the airport is difficult for them, that they don't want to go. Okay? So they really want to avoid it at all cost. For me, I don't like it, I'm scared of it, but I still go on flights. So I wouldn't say I have phobia. Okay? I'm scared of it. Okay? There is hemophobia, which is fear of blood. I have a friend who is scared of blood, that the sight of it makes her faint. Okay, and then there's trypophobia, which is a fear of holes. Now, when we look at this, does that make you scared or does that make you disgusted? Okay, so for us, for phobia, it doesn't only make you scared, but also certain emotion. For example, you're disgusted by it. So that's phobia. Okay. There's also agoraphobia. I don't know if you have heard of it. So this is the fear of going outside. Okay. Now, um, there is a case where this person hasn't left her house for years. Okay, because she's just scared of the outside. Okay, what are the possibilities of happening outside? So she stays indoor for years. Okay, that's phobia. Okay, so symptoms of it: sudden outbursts of disproportionate rage, other intense motion, feeling loss of control if they go outside, they're trembling when they go outside, fear of leaving home alone, fear of enclosed spaces, extreme idealization and devaluation in relationships. Okay, I'm gonna show you a short video that will explain more about phobia, which I think was really great. I understood phobia when I looked at this video. Okay.
Everybody, whether they like to admit it or not, has fears and gets anxious about certain things, whether it be a spider crawling on the ground or getting up in front of large groups of people. In most cases, though, people cope with those fears and confront them. A phobia is the most extreme type of fear, where it actually causes them to go to great lengths to avoid being exposed to the feared or perceived danger, even if there's no actual risk or danger, and people often feel powerless against it. Phobias are considered the most common psychiatric disorder, affecting almost 10% of the population. Phobias are extreme, often unreasonable and irrational fears of something, which could literally be anything, like pyrophobia, fear of fire, electorophobia, fear of chickens, triskaidekaphobia, fear of the number 13, phobophobia, fear of developing phobias, or even pinacophobia, a fear of lists. Unreasonable or irrational fears get in the way of daily routines, work, and relationships because patients with phobias might try to do whatever they can to avoid the anxiety and terrifying feelings associated with the phobia. For example, most people don't necessarily enjoy the company of a spider, but they also don't let it affect their social or daily life. Like, even though I know there are spiders in the woods, I wouldn't avoid a camping trip on account of the spiders. Even if they love camping, somebody with arachnophobia, a fear of spiders, might refuse to go because they know there's a possibility of seeing a spider in close quarters. The fear is clearly interfering with their social life and relationship with friends, meaning it's a phobia. An irrational fear of an object or situation like this is called a specific phobia. The Diagnostic and Statistical Manual for Mental Disorders, edition 5, splits these specific phobias into 5 categories. Fear of animals, like arachnophobia or electorophobia. Fear of the natural environment, like darkness or nyctophobia. Fear of blood and needles, hemophobia. Situational fears, like fear of flying, aviophobia. And then other fears, like fear of clowns, coulrophobia. These specific phobias are one of 3 main types of phobias. The other 2 types are agoraphobia and social phobia. Agoraphobia means fear of public places, but has to do with being fearful in a public space where it feels like it might be hard to escape quickly and return to a place perceived as safe, like the person's home. Therefore, people with agoraphobia tend not to venture out very often. Some commonly feared areas might be places like crowded shopping malls or theaters, where it might be difficult to escape quickly. Social phobias, on the other hand, are overwhelming and persistent fears of social situations and interactions. People with social phobias are fearful of being embarrassed or judged by others. Being embarrassed or feeling awkward in a social interaction from time to time is totally normal. But people with social phobias often feel anxiety for weeks leading up to events before they happen, and are afraid of doing common things in front of others. For example, someone with a social phobia might be afraid to eat in front of someone else. For people with phobias, seeing, being exposed to, or even thinking about the phobia causes severe anxiety that's often not proportionate to the real threat. They'll catastrophize and jump to the worst case scenario and think that it's more likely to happen than it actually is. These thoughts can lead to physical symptoms like excessive sweating, trembling, and an increased heart rate. That being said, it's important to reiterate the difference between an everyday fear and a phobia. Feeling queasy while you're climbing a ladder would be an everyday fear. Avoiding your favorite frozen yogurt place because it's on the 2nd floor of a building would be a phobia. Feeling weirded out around your best friend's pet snake is an everyday fear. Avoiding your friend's house entirely because they have a snake would be a phobia. Unless it's not in a terrarium and slithering around the house, then I guess it would be an everyday fear. Basically, it comes down to the idea of what would be an appropriate or reasonable response versus a disproportionate or exaggerated response. But what causes a phobia? Well, we don't really know. But we do know that you're more likely to develop one if you have a family member with a phobia. Sometimes, though, phobias might be caused by specific traumatic events, like being confronted by an aggressive raccoon. Now, tailoring treatment for a specific individual's fear is super important in effective therapy, because different patients might respond differently depending on the therapy, especially if other conditions are involved, like depression and drug abuse. Psychotherapy, particularly cognitive behavior therapy, can be super beneficial for patients. Cognitive behavior therapy teaches patients to be mindful that their fear is irrational, and the likelihood of their worst fears coming true, like being attacked by a pack of angry raccoons and getting rabies and dying an unpleasant, untimely death, is actually very low. Also, systematic desensitization might be used, where a person is gradually and systematically exposed to the feared objects. Patients first learn to identify the anxiety, then they learn coping techniques, and last they use their learned coping techniques to overcome situations. The vast majority of patients can be treated using these tailored methods.
Okay. Okay, so I hope you have a clear definition of phobia in your head now. Okay, so there are differences with someone with phobia and someone who is just scared of something. Okay, someone who has phobia will actually have the worst case scenario in their head. Okay, irrational expectations. Okay. Okay, now, so today we're gonna see look at phobia and its connection with classical conditioning again. Okay, so this was actually investigated by Ivan Pavlov, who observed dogs salivating in a laboratory when they were totally different, doing a totally different experiment. So he wanted to investigate why they salivate. Okay, so classical conditioning, a process that involves creating an association between a naturally existing stimulus and a previously neutral one. Okay, now this is what we looked at. So obviously, when a dog sees a food, their natural response is to salivate. Okay, now before we do conditioning, when we give them a whistle, obviously they will not salivate. Okay, but if we pair these two together for a couple of times, not just once, okay, for a couple of times, obviously his response will be salivate, okay, because he sees food there. So after a few trials of this, if we present just whistle, he will start to salivate because he has associated whistle with food. Now we can also do this with phobia. Okay, so for example, this dog, what was I saying? Sorry. Okay, so they did it on the child as well. Sorry, guys. They did it with a child. Okay, so a 9-month-old called Albert. Okay, now we present him with a different stimuli. Okay, and see his reaction. Now this time they present a rat. Okay, which at first he did not respond unnaturally. So basically, he was okay with the side of rat. So now when we present the rat, we keep banging. Okay, we keep banging, so there's a loud noise every time there's rat. Okay, so whenever he sees rat now, he will become scared. Okay, because he has associated the loud noise with rat. So whenever he sees rat, he has paired this with a loud noise which he sees, which he perceives as a threat. Okay, so we have conditioned his phobia. Okay, now phobia and classical conditioning. Some psychologists believe that abnormal behavior such as phobias can be both learned and unlearned in the same way as any other type of behavior. So here he has learned the fear of rat because it was paired with a loud noise. Now we believe that he can also unlearn it. Okay, unlearn the phobia. So there are two types of classical conditioning. One is expectancy conditioning, second is evaluative learning. So expectancy conditioning is a previously neutral or non-threatening object. For little Abbott's case, it was the it was the rat. Okay. So becomes associated with a potentially threatening outcome, which was a loud noise. The consequence is that the individual expects a negative outcome, so experiences fear in the presence of the previously non-threatening situation. So the outcome would be fear when he sees that non-threatening object in the first place. So now it becomes a threatening object. Okay, so it resulted in fear. So that's expectancy conditioning. Evaluative learning, same thing. However, the individual forms an association between a previously neutral stimulus and a negative emotion. Okay, so it's not a threat but rather a negative emotion, but this is a negative evaluation. For example, disgust rather than fear. So in evaluative learning, when we pair those two, it results in disgust. Okay, so that's the difference between these two. Here it results in fear, here it results in disgust. Okay, so let's have a look at expectancy conditioning. So I have a friend I've told you before who has a phobia of bananas. So she didn't always had it. Okay, so she has learned it. Okay, so this was her case. Before conditioning, she has neutral response to banana. Okay, before conditioning, we are all scared of ghost. Okay, so this one time, not just one time, a few times, she has seen ghosts in this banana tree. So she has conditioned, she has associated bananas with ghosts. So now whenever she sees bananas, she's scared. It results in fear. So that's expectancy conditioning. Okay, evaluative learning. Okay, there was this case of about this chef who has a phobia of baked beans. You know what baked beans is? The ones that we eat with eggs usually, the one in cans. Okay, okay. So he didn't always have it. He didn't always have a fear of baked beans. So this is what happened before. the conditioning, um, he has neutral response to baked beans. Okay, neutral response. He can handle beans, and then but then he is always bullied by his brother. Okay, who is always throwing things at him. Okay, um, throwing rubbish or things like that. So he's disgusted. Okay, so this one time, the brothers actually threw baked beans to him. So now he feels disgusted. So now whenever he sees baked beans, he feels disgusted. Okay, because it reminds him of his brother. Okay, so he actually had to retire from being a chef because he couldn't handle baked beans. It makes him disgusted. Okay, so that's evaluative learning. Rather than scared of beans, he just can't handle it because it's just disgusted by it. Okay, now since classical conditioning can cause phobia, so can we use it to treat phobia? Okay, disgust as well as fear may be an appropriate target emotion for the treatment of phobia, as well as the primary emotion of fear. So example studies were Hepburn and Page in 1999. Treating patients' disgust as well as their fear helped them to make progress with their blood phobia. So basically, in this treatment, they focuses on the feelings, the disgust and the fear, rather than they focuses on the blood. Okay, so they talked about the rather than talking about the blood, they talk about their emotion. Okay, De Jong et al. Worked with children who had a spider phobia. Although no attempt was made to manipulate feelings of disgust, their feelings of disgust decline alongside their reduction in fear. So basically, when we want to treat them, we want to target the emotion of it. Okay, so let's talk about Saavedra and Silverman. So this is a 9-year-old Hispanic American boy who has a phobia of buttons. The phobia had begun at age 5 when the boy had knocked over a bowl of buttons, okay, in front of his class and teacher. He found the incident distressing, and from that time onwards, his aversion, also he's been avoiding buttons, okay, his aversion to buttons steadily increased. The phobia was interfering significantly with his normal functioning that he could no longer dress himself and had become preoccupied with avoiding touching buttons or clothing that could have touch buttons. So it has affected his daily life, guys. Okay, so um, so in this study, we want to examine the role of classical conditioning in relation to fear and avoidance of particular stimulus. In context of specific phobia, which is a phobia of buttons here, researchers wanted to see if using a type of exposure therapy could reduce the disgust and distress associated with buttons. Okay, we will look at exposure therapy later. Okay, now this was a clinical case study as it involved just one participant, okay, whose life history and treatment was studied in depth. Data was collected using self-report measures. Both the boy and his mother were interviewed by the researchers about the onset of his phobia and his subsequent behavior. The results of the treatment were measured using a 9-point scale of disgust known as the feelings thermometer. So at the end, after all the therapy, this is how we see whether the treatment worked or not. We will be using scale, okay? So since it's a case study, it involves studying one or a very small number of participants in great depth. And it's particularly suitable in researching phenomena that are unusual or rare. So this is quite unusual, which is studying someone with a phobia of buttons. Who's the sample? It's a 9-year-old Hispanic American boy. Along with his mother, he had sought support from the Child Anxiety and Phobia program at Florida International University, Miami. He met the criteria for having a specific phobia of buttons. So he was diagnosed with phobia, okay, and had been experiencing symptoms for around 4 years prior to the start of the study. So this study was done in 2002, so he has it since 1998. Okay, so what is the criteria? What is the symptoms? What is now, in psychology, when we want to diagnose someone with depression, they have to meet the criteria of what we call a DSM. Okay, so DSM is this is how you would want to diagnose. If they meet the criteria of someone, if they meet the criteria, then we can diagnose them. So this is the criteria, the ESM criteria for having a phobia. Marked and out of proportion fear within an environmental or situational context, the presence or anticipation of a specific object or situation. For him, it's buttons. Exposure to the phobic stimulus provokes an immediate distress. Immediate, okay, guys. The rapid onset, okay, or anxiety response, which may take the form of a panic attack. So avoidance and anxious anticipation or distress in the feared situation interferes significantly with the child's normal routine, which he had, which was he could not dress himself using dress that has buttons. Okay, not dress, shirt that has buttons. Academic functioning or social relationship. Now, um, I would have think I would have thought that he would not be functioning well academically if, let's say, it was the school had a uniform, so everyone else is wearing a shirt with buttons, and he's surrounded by that. How do you think he would react? Okay, so I wouldn't say he would have been focused. So his academic function was not great. Okay, the symptoms might have duration of at least 6 months. He has it for 4 years now, so he has met the criteria for someone who has a phobia. Okay. So, what was the procedure? The boy and his mother both provided informed consent to participate in the study. They were interviewed in order to determine whether any trauma or abuse could explain the boy's phobia. It was necessary for the researchers to understand the boy's specific feelings toward buttons prior to starting treatment. Through discussion with the participants, they created a hierarchy of fear stimuli, with each item on the list provoking increased fear. Okay, so basically, if it's rated 0, it doesn't cause any stress. But if he rates it 8, that's very distressing for him. So let's see. For him, when he sees a large denim jean buttons, that's just a 2 for him. So it's not that distressing for him. But these are the things that he's most scared of, which is small plastic buttons, colored, and small plastic buttons, clear. Okay, so these are actually the buttons that he dropped in that first incident in the class. Okay, it was a ball of plastic buttons. That's why this is the most distressing for him. Okay, so the most difficult items for the child were small, clear plastic buttons. These were rated at an 8 on the 9-point feelings thermometer. So this is what you call a feelings thermometer. Okay, handling this or touching someone wearing them was the most unpleasant task for the boy. So what was the treatment that was given to him? Okay, first is exposure based treatment. um, the behavior focused approach, which meant the boy was rewarded for showing less fear and for actually handling the buttons. The positive reinforcement was given to the boy by his mother only after he had completed a gradual exposure to buttons. Now, before I talk about him, let's talk about exposure based therapy. So, for someone with height, one of the way to treat them is basically for them to face the fear. So, um, as a psychiatrist, what they would do would be they would bring them to if you looked at video just now, fear of height is basically someone who doesn't even want to go on a second store shop because it's high up there, so they avoid it. So that's someone with that. So one way to treat them is to expose them to height. So if you one way for them to do it would be they would start gradually, so they don't just go straight away go to the mountain. No. Okay, so they start from the bottom. So maybe start them with the first floor first. Okay, and then if they're okay, move on to second floor, so gradually. And this don't just happen one day. Okay, sometimes it takes over the course of months. Okay, so it would take them 2 months, let's say, for example, just to get him to get to the second floor. Okay, so here, same thing. So what they do is, obviously they will start with this button first. Okay, expose them to this button first. We don't straight away go to this. Okay, we make them touch or approach these things first, and then gradually go up the list. Okay, so he will only be given positive reinforcement if he had completed, if he had reached these buttons. Okay, so they did that in 4 sessions. Okay, imagery exposure. This one, exposure based treatment is basically to they use this if someone had a fear for it, but for someone who is disgusted, so which is uh like um like this boy right here, he is not scared but rather disgusted by it. Okay, so they also did imagery exposure, which works well for disgust related phobia. Okay, so disgust related imagery exposures were incorporated with cognitive self-control strategies. The boy was asked to imagine buttons falling on him, and to consider how they looked, how it felt, how it smelled. Okay, he was also asked to talk about how these imagery exposures made him feel. The exposures progressed from images of large to smaller buttons. Okay, so as you can see here, large ones are okay for him. It's the smallest one that he had difficulty with. Again, gradual exposure. Okay, in line with the boy's fear hierarchy. Okay, in imagery exposure, we found that interviews with the boy had revealed that he found buttons touching his body disgusting. It's not so he's not scared of it. It's just he's disgusted by it, and he also believed that buttons smelled unpleasant. These ideas form the basis for discussed imagery exercises. Unlike in vivo exposure just now, where the individual actually physically handles or is exposed to fearful stimuli, imagery exposure uses visualization techniques. So here we're only visualizing. There's no buttons present. They're just visualizing it, imagining it. Okay? So here, so what do they do when they imagine it? Okay, so they were taught how to do self-control. Okay, so it's a form of cognitive behavior therapy. It involves using self-talk. The individual is taught to recognize difficult situation, acknowledge troubled thoughts, and consider alternative positive thoughts. Okay, so let's say he says, so he's imagining the buttons falling him in, and he says it's disgusting. So the therapist will teach him how to control his self. Okay, so basically, him talking about, okay, so it's just buttons. It will not smear your shirt or things like that. Okay, so they're taught this self control. Okay. So this was done for 7 sessions. The exposure therapy was 4 sessions. The imagery exposure was 7 sessions. So how did that go? For positive reinforcement therapy, which was the exposure therapy just now, the outcome of this therapy was a successful completion of all the exposure tasks listed in the hierarchy of fear. So he did expose up until the last one, which was he was exposed to all this. Okay. The boy also observed approaching the buttons more positively. One example of this was that he started handling larger number of buttons during later sessions. However, his subjective ratings of distress increased significantly between sessions 2 and 3. So he did it in 4 sessions, guys, remember? But actually, by session 2 or 3, when he was doing the feeling thermometer, his rating actually increases. He was actually in distress, okay, and continued to rise. By session 4, a number of items on the hierarchy, such as hugging his mother while wearing buttons, had increased in dislike from original scores. So, despite his behavior towards the fearful stimuli improving, his feeling of disgust, fear, and anxiety actually increased as a result of the positive reinforcement therapy. So he could handle it, but however, when we talked about his feelings about it, he was still actually scared and disgusted by it, even though he could handle it. Okay, so it's not really working internally. Externally, he looked like he could handle it, but when we talked about it, his feelings was actually in worsen. Okay, the finding is consistent with evaluative learning. Despite apparent behavioral change, evaluative reactions remain unchanged or even increase. Okay, so for the image exposure therapy, okay, this appeared to be successful in reducing the boy's rating of distress. One example of this is shown in Figure 1.6, relating to the imagery of hundreds of buttons falling over its body. As you can see, after the third session, his ratings decreased from 8 to 3. Okay, this reduced to 5 midway through the exposure, and just 3 after the exposure was complete. Okay, so unlike the positive reinforcement therapy just now, even though he could handle it, but when they did the rating, it actually increased. Okay, so that was when they were physically exposed to it. So when they did image exposure therapy, when they did some visualization and they focused on the discuss, and then they were taught how to self-control themselves, it actually reduces the severity rating on the feelings thermometer. Okay, so which one worked better for you? For me, the image exposure therapy. Following his treatment, 6 month and 12-month follow-ups were conducted. Okay, at these assessment sessions, the boy reported feeling minimal distress about buttons. He also no longer met the diagnostic criteria for a specific phobia of buttons, so he's no longer diagnosed as someone with a phobia. His feelings for buttons no longer affected his normal functioning. He was also able to wear small clear plastic buttons on his school uniform on a daily basis. So what can we conclude? The researchers concluded that the treatment was successful. In particular, they argued that emotions and cognition relating to disgust are important when learning new responses to phobic stimuli. Imagery exposure can have a long-term effect on reducing the distress associated with specific phobias as it tackles negative evaluations. Okay, so between exposure therapy and imagery exposure therapy, imagery exposure was best when reducing the distress as it tackles the negative thoughts, negative feelings, negative disgust of buttons. Okay, and that's it. This is for you to look at. Okay, I've done a bit of research, I've done some evaluation. Now we will talk about this. We will do evaluation next time. Okay, thank you for listening.